Thank you. So hi, my name is Luxey, and today I'll be talking about service delivery for older women living with HIV, what geriatricians can do for women living with HIV who are aging. I would like to recognize the Nanochek and the Piscataway people, the first residents of this land that would become the District of Columbia. I have no conflict of interest to disclose. So for my presentation objectives today, I want to provide an overview of the unique challenges and considerations related to HIV, aging, and gender, particularly focusing on older adults and women. And I want to introduce the role and significance of geriatricians in addressing the healthcare needs of older adults living with HIV, emphasizing their expertise, responsibilities, and motivations. Sorry. Let me go back. Okay, there we go. Okay, so there's something that we are all doing together right now in this very moment without realizing it. We are all aging. Woo! So to put it simply, aging is a process of getting older. It is associated with biologic, physiologic, psychological, social, functional, and spiritual changes. Aging is unique for each and every person. Your aging is going to look different from your neighbor's aging, and it's going to look different from my aging. Aging has and will have an impact on all of us, and it is my mission to change the narrative from aging as something that we don't look forward to into something that we do. A geriatrician's mission is to help others age well. For the purposes of this talk, I will use the definition of an older adult living with HIV as a person who is 50 years of age or older. The reasons for this is because older adults living with HIV have impaired physical function, higher frailty, and more frequent geriatric syndromes. Those are syndromes that are found in aging like falls and dementia, but more on that later. These are contributing factors to why their chronological age does not match their biological age. And for this talk, the definition of a woman refers to biological sex. Women were not required to be included in clinical trials until the 1990s by the National Institutes of Health. And up to 2019, older adults were not required to be included in the NIH-funded studies either. Now, when you add the additional layer of being an older adult, a woman living with HIV, you can only imagine the clinical research and the lack thereof that exists. So we've established that there's a vacuum of knowledge with the specialized population. How can we as geriatricians help? Well, in order to understand this, it's important to understand our role and how we help people age well. So geriatricians are specialists in geriatric syndromes and experts in aging. The definition of geriatric syndromes is that there are multifactorial health conditions that are common to older adults that occur when accumulated effects of impairments in multiple systems cause an older person to be vulnerable to situational changes. So these are some examples of geriatric syndromes, and they include things like dementia, falls, and frailty. We create multidimensional assessments and individualized management styles called comprehensive geriatric assessments. Geriatricians have been found to reduce mortality, improve overall survival, decrease discharge time to nursing home, reduce medical costs, reduce the number of drugs prescribed, reduce frequency of outpatient clinic visits, and reduce emergency department visits and hospitalizations. So comprehensive geriatric assessments, I keep throwing this term around, but what exactly is it? Well, it's a comprehensive evaluation of existing medical, functional, and social needs in frail older adults. And we really use an interprofessional approach to manage complex and often interrelated issues. We improve a person's functional abilities and quality of life in line with their goals of care. That's very important. And we consider the needs of involved family and caregivers. Now, I'm just going to flash up here the World Health Organization's HIV service delivery definition. You can see that there are many commonalities. It's comprehensive. They talk about families and caregivers and service delivery that's people-centered. It's easy to see that CGAs is essentially HIV service delivery with the added layer of treating for geriatric syndromes and aging. So as you can imagine, coming up with a plan for how to age well is a fairly daunting task. So we've developed a simple framework as geriatricians to help us guide our care. The framework that is used globally is called the 5 M's of geriatric care. So we have mind, mobility, medications, multi-complexity, and the last, which is what matters most, meaning what matters most to the patients and us. Okay, so we have talked and established that older women with HIV are aging, and little research has been done in this area. We know that geriatricians are experts in aging, and we know that they improve outcomes of older adults. And we know that the HIV service delivery and comprehensive geriatric assessments are very similar, just with that added layer of aging. What if geriatricians and HIV specialists team up? Well, I'll apply that 5M framework to this population, and it will help illuminate where and how geriatricians can help women with HIV who are aging. Let's talk about the mind. So when I say dementia or cognitive impairment, I want to define what that really means. Dementia is an umbrella term that describes a variety of diseases whose symptoms are memory, language, problem solving, and other types of thinking that interfere with daily life. What causes dementia? Well, that's the billion-dollar question, but we know that there are comorbidities that do contribute to cognitive decline, such as cardiovascular disease, hypertension, diabetes, and stroke. And we know that this is already found in older adults, but we also know that people living with HIV have increased rates of these as well. When we look at women in particular, it has been shown that women have increased rates of dementia. Studies range from about 46 to 80% for women versus 38 to 73% for men. And what is interesting is that this trend of older women having increased rates of dementia have been found in lower, middle, and high-income countries. There are very few studies that did actually have enough power, i.e. enough women in them. However, 2 done in 2018 were quite notable by Sunderman and colleagues and Mackey and colleagues. The fact that there are only really 2 studies that were adequately powered for this population is telling. HIV-positive women compared to HIV-positive men showed cognitive vulnerabilities in psychomotor speed, attention, processing speed, motor skills, verbal fluency, learning, memory, and global impairment. HIV-positive women showed a 76% increase in decline in the global estimate of cognitive function over a 35-month follow-up, meaning that they're declining faster. It is important to note that these studies controlled for HIV-related clinical characteristics like CD4 counts, viral loads, and medication use, which brings us to the big question: what could explain this? Well, many theories have been postulated, and each of these points and more can be an hour talk long, so I'll give a bird's eye view. But from a biological perspective, cognitive performance can be affected by the interaction of endocrine variables like menopause and HIV infection. There also may be sex differences in HIV-associated brain structures and alterations, as well as systemic immune inflammation to HIV. From a psychosocial point of view, years of completed education is protective for cognition, and higher levels of education are often associated with better cognitive performance. Women still tend to have less access to education, like in the Mackey, and I want to point out that in the Mackey study, reading level and years of education were more strongly associated with cognitive performance compared to their HIV status. With psychiatric factors, specifically depression can impact and has impacted cognition in women more likely than men, and they're more likely to report severe symptoms. And lastly, issues like substance abuse, food insecurity, childhood trauma, socioeconomic status, all influence cognitive performance and impact women more. Geriatricians are experts in cognition and maximizing patients in terms of their risk factors for worsening cognition. We can help address and potentially reverse these. So here's a graphic from the 2020 Lancet Review article on dementia that geriatricians use to help come up with cognitive plans. And you can see that there are many risk factors like hearing, education, hypertension, substance abuse and substance use, depression, physical inactivity, and social isolation that are potentially modifiable by up to 40%. So we can help work with HIV specialists to come up with plans for the patient, for our patients. Next, I'd like to talk about mobility. So for mobility, it's a constellation of systems, but for this talk, I'm going to break it down into 3 major components: bones, muscles, and then using them together to talk about falls. So first, the muscle. Well, sarcopenia is defined as the loss of muscle quality and quantity. And we know that women undergo an accelerated loss of muscle mass at an earlier age than men in general at the time of menopause. With regards to those living with HIV, therapies like zidovine and NRTIs are associated with myopathies because of their impact on mitochondrial DNA. Even ART therapy has been associated with mitochondrial stress as well, and this has been linked to sarcopenia in older adults living with HIV. So, compounded with being an older woman living with HIV, this increases their risks of sarcopenia. When we talk about bones, here's a validated fracture risk assessment that I use all the time in my clinic to help calculate a patient's risk for fractures. In this tool itself, you can see that there are multiple risk factors that we've already established are prevalent in older women living with HIV, including being a woman, having lower body weights, smoking, alcohol use. They're all factors that increase risk of fracture. Studies have shown that people living with HIV have an accelerated rate of a bone loss and are diagnosed with low bone mineral density at younger ages. Menopause transition may also be a vulnerable period where changes in BMD loss are enhanced due to immune activation. It has been shown that older women living with HIV and low bone mineral densities are at a 3-fold higher risk of osteoporosis, putting them at risk for fractures that could be life-altering, impacting their function, leading to disability and mortality. So taken together, we'll talk about falls. We already know that people living with HIV are falling younger, but when we look at the risk factors that women face in particular, we already know that they have cognitive impairment as well as neuropathy and an increase in frailty, putting them at a higher risk for falls compared with men. Geriatricians can help because we're fall experts. We look for medication culprits, blood pressure drops, fall risks in the home, other pathology that can explain these falls, and fall prevention measures. We can also be proactive about osteoporosis treatment and workup. So the next 2 M's I combined together, and you'll see why, as they're often quite intertwined: medications and multimorbidity. So multimorbidity is defined as 2 or more long-term health-related conditions that are 3 times higher in older adults living with HIV, and polypharmacy, which are 5+ drugs, which are 2 to 4 times higher in people living with HIV. So the proportion of people living with HIV with multimorbidity has nearly tripled since the year 2000, and this is a 3-fold higher rate of multimorbidity in older versus younger people living with HIV. Naturally, this results in the use of multiple medications increasing, thus leading to leading to polypharmacy. An excellent study done by Rubin and colleagues for older women showed that hyperpolypharmacy was associated with poor cognitive function. Women with polypharmacy were also associated with poor executive function, i.e. the ability to plan and to execute actions like driving and processing speed, in contrast with men living with HIV. And the last M, which is what matters most, is the most important. It's important to note that the literature review to support this slide uses the term woman to refer to gender and not sex. An Australian study found that older women living with HIV were well below the Australian average for finances. More than half experienced significant financial stress, and 1 in 3 experienced food insecurity. Older women were found to be geographically dispersed and often isolated, exacerbating social isolation and making it challenging to receive social supports. Based on our forthcoming review that I'm working on with our team, qualitative studies have found that women living with HIV are seeing their greatest concerns or stressors that they have found, aside from the deep impact of HIV-related stigma for many, was not their HIV, but poverty and financial stress, lack of information, and social support that were their largest stressors. Additionally, domestic violence. Thank you for the talk yesterday. I changed my slide from intimate partner violence. Immigration status, housing insecurity, living conditions are at the forefront of their worries. Women have complex social contexts, particularly with gender roles like being a mother, a carer, a partner, and have resulted in decreased capacity for self-care as women prioritize responsibilities embedded within their gender roles, despite the severity and impact of managing multiple comorbidities and impacts of HIV treatments. Focus on the needs of family often restricts social participation and further exacerbates social isolation. They also talked about their lack in their healthcare providers understanding their unique aging challenges. They found that women lacked a voice in terms of looking forward to their aging and setting dreams. They had a reluctance to set goals. And I wanted to really take a moment to talk about stigma. So approximately 7 in 10 older adults living with HIV experience HIV-related and age-related stigma and trauma. This has been dubbed as the double stigma, but you could argue that there's actually a triple stigma, one being a woman aging with HIV. Older adults are already not really seen as an HIV risk group due to the misconceptions that they're not sexually active and ignoring their sexual health needs in the global response to HIV. Women and men are both less likely to use condoms in their older years, thereby increasing their risks. Healthcare providers are less likely to discuss testing or other related issues with older adults as well. And I wanted to talk a bit about future planning. There have been studies that have shown that older adults living with HIV have been facing discrimination as they seek long-term care and long-term care services. And unfortunately, long-term care providers have very little knowledge of HIV and are unaware of their legal obligations to provide housing and services to individuals living with HIV. Women may face increased stigma from other patrons of long-term care who may have cognitive impairment, preventing them from being able to be educated about HIV in general, resulting from isolation in others. Additionally, women are seen as on the prowl in long-term care if they sit with men, which could lead to further stigma for older women living with HIV, just attempting to make social connections. They may also face a lack of education from staff members in the long-term care who understand HIV. This could lead to altered care, i.e. wearing gloves when they're not needing to, staff not understanding how transmission works, and leading to poor hygienic care. And we already do have studies that show that they have increased hospitalizations in compared to other long-term care patrons. So feeling well, aging well, doesn't really necessarily equal to a low viral load. We have to change our approach to older women living with HIV to a more holistic one. So that's it. That's the 5 M's of geriatric medicine in a nutshell. But let's talk about what geriatricians can really do to help. Well, we have come up with some potential models of care, one of them being outreach programs where geriatricians like myself go into the home, but that has a lot of inherent biases, like that the home is safe, that they're in a stable financial place, and that geriatricians even are able to go and see them, given that their catchment area incorporates their homes. We are working on a virtual geriatric care program where we do virtual assessments, but again, that has a lot of inherent biases, specifically with safe living conditions and having access to technology. We have looked at education for primary care as well, creating toolkits for primary care providers to address aging and older adults. But this also then relates to stigma in healthcare and geriatric co-management with HIV experts. So for some concluding thoughts, with comorbidities and age-related transitions, older women with HIV may experience a range of health challenges. Recognizing and managing these conditions and comorbidities is essential to providing undertreatment and ensuring better health outcomes. For research addendas, there's a need for comprehensive research for older women, including large and longitudinal studies examining the natural history in this population. Policy guidelines are necessary and policy shifts are essential to address power differentials, discrimination, and systemic barriers faced by older women. As I said at the start, aging has and will have an impact on all of us. It is now our mission to help change the narrative for older women living with HIV and help ensure that they're aging well and on their own terms. Thank you.